I'm very grateful to be here and to be able to talk to you all about what's happening with naloxone in Scotland. My name's Kirsten Horsburgh. My official title is the National Naloxone Coordinator in Scotland. I'm not by any means an academic or a researcher. My background's in mental health nursing, so probably what I'll be slightly different today is I'll give you a more practical look at what's happening with naloxone in Scotland. And hopefully that'll give it a slightly different angle, and if not, I'll just get my coat. But I'm here in Australia, really lucky to be here as part of a travel fellowship from the Winston Churchill Memorial Trust. So I'm travelling around different parts of Australia, and I'm going over to Malaysia for the Harm Reduction Conference to look at ways of reducing drug-related deaths here, and with a kind of sideline agenda of trying to promote the use of a supervised injecting facility in Scotland. Because whilst I'm a huge believer in the naloxone programme and certainly believe that naloxone should be available to everyone who has a history of opiate use or who's currently using opiates, it's certainly not the only thing that we can be doing to reduce drug-related deaths. So for the next half hour or so, I'm going to give you an insight into what's happening with drug-related deaths in Scotland, exactly what we're doing and maybe what we're not doing to try and address the problem, more about how the community naloxone programme functions, and then a focus on exactly what's happening in the prisons. I've promised to try not to rant about a couple of things. There are certainly some frustrations about what's happening in Scotland, and there is no way you'll understand me if I start ranting in a Scottish accent, so I'll definitely try and not rant. So just to give you some figures for the population size and the problem in Scotland, we have about 5.2 million people living in Scotland. We have 14 health boards across the country, so all health boards bar one are signed up to supplying people with naloxone. So up towards the top left, that little blob on the left is NHS Western Isles. They're the only area in Scotland who don't provide take-home naloxone. That decision was made by them at the very start of the programme, and I'm unsure of the reasons for it, and I keep threatening to go there on holiday and just drop off a load of kits, and that'll be them with a programme because their numbers are so low. So we have 30 alcohol and drug partnerships, so these are local partnerships that are tasked with, amongst a whole load of other things, reducing drug-related deaths in the communities, and they're funded by the Scottish Government. So they've been responsible for ensuring that the naloxone programme is happening in their areas. So some health board areas will have one ADP, some will have 6, depending on the size of them. I live in a particularly small health board area in Scotland in the Scottish borders, and we have one ADP and a small population, about 700 people with problem drug use, but we're going to look at the whole picture. So we have 15 prisons, and I'm going to talk more about them slightly later, and all 15 prisons are signed up to supplying people with take-home naloxone at the point of liberation. Around 60,000 people with problem drug use, and in Scotland we're talking about heroin and or benzodiazepines. And just to give you an idea, these are all the council areas across Scotland. So the areas with the highest amounts of people with problem drug use are areas, as you would imagine, with high levels of poverty and deprivation. So Glasgow City having the most. We have around 23,000 people known to services, and around 25,000 people receiving opiate replacement therapy, and mostly methadone. So when we're talking about numbers of people who've been supplied with naloxone, that's a really important point to remember, because it should just be part and parcel that anyone on opiate replacement therapy is also afforded take-home naloxone. So this is the picture that we have of drug-related deaths in Scotland. So since the recording started in 1996, we've had this increasing trend of drug deaths. So quite a bleak picture. We're on an upward trend and still have been. It came to a peak in 2011, where there were 584 people who lost their lives, and then the following 2 years we had slight reductions, and there was some hope there that we would continue to see reductions, and my statistician colleagues would tell me that I could only say that if it had been 3 to 5 years reductions, and then of course 2014 comes and we see a huge increase again in the number of deaths, so 613 people lost their lives. Important to remember that these figures are overdose deaths only. So they're not deaths from road traffic accidents, bloodborne viruses, bacterial infections, violence, anything else to do with drug use at all. These are purely from overdoses, so hence they're accidental and they're preventable on the whole. Some of them will be intentional, but we don't know that unless the person's left a specific note or has told somebody of their intention, so generally they would all be accidental. So every August we have our drug death figures released, and it gives us the numbers of people who died, the areas in which they lived, the drugs that were in their systems, and then about 6 months later we have a drug-related death database report, and that gives us the numbers and a more individual look at the circumstances. We have an emergency, it's distracting me for a moment. So yeah, we have a more individual look at the circumstances surrounding the deaths, and the ADPs in the areas are responsible for collecting that information about the people in their areas who died, and that information is collected in a report that's published. And that gives us a look at the common circumstances, which tend to be that people are more likely to die in their own or a friend's home. They're likely to have had a recent non-fatal overdose and someone knows about it, or they've maybe been admitted to hospital. There's often several hours between the actual overdose and the death, so it's not something that happens instantly, as we know. And in about 98% of cases, other drugs are present, so it's not individual substances. So polydrug use is no different from anywhere else. It's definitely one of the main problems that we have for drug deaths in Scotland. And our main substances are heroin, methadone, alcohol, and benzodiazepines, and diazepam being our choice of benzo. We find it's older, more experienced injecting drug users who are likely to die. And when we're talking about older drug users, we're talking about people aged 35 plus, which is by no matter means old, but certainly when people have had that longer history of drug use and that accumulative effect and lots of physical health problems. We see lots of people having had breathing difficulties reported, maybe bloodborne viruses or chronic liver damage, so certainly that's a big issue. Persons likely have had a recent abstinence or a reduction in their use, so they've perhaps been in prison, or they've maybe been in hospital, they've maybe been in residential rehab or some detox facility. So all these places, really high risk and certainly reduce people's tolerance. They're likely to have had some kind of reduction in their tolerance before they die. Persons not likely to be in treatment, but from what we know, most people who die have been in contact with services within the 6 months prior to their death. So this is always an area that I rant about. I deliver training across Scotland to people, to staff working in frontline services, nursing staff mainly, or staff working in third sector. And one of the issues that always comes up is about retaining and engaging people in treatment, and normally when I'm talking about treatment I mean on prescribing. So we seem to have developed this punitive practice in a lot of areas that has existed for many years and is very prehistoric, but it certainly exists in some areas where people will be discharged for using on top of prescriptions or missing appointments. They'll often be told that we're discharging you from service to go and work on your motivation, so don't come back to the service for 3 months until you've done so, if you're lucky enough to survive. So this is always an area of contention, and certainly I have had some very heated training sessions with nursing staff in particular who find this a really hard concept to grasp. It's not a secret that people are safer from overdose deaths if they're in treatment. So why do we keep insisting on having this treatment service where it has a kind of punitive aspect? So certainly for me, it's an area that I always drive home when I'm delivering training. Look, we can prevent overdoses by helping people to stay in treatment as well when they need it. And the other factor is that witnesses are present most of the time when somebody else dies. So it's generally other drug users, but sometimes it will be family members, friends. Sometimes it's been staff in services. So we've had some really tragic cases where people have died in custody and they've been checked on, they've been seen to be intoxicated, they've been checked on, and they've been recorded as asleep snoring every 15 minutes, with no recognition that that was a sign of overdose, and they've watched the person die. So really important as well that people are aware of the signs and symptoms of an overdose and know how to respond regardless of whether naloxone is available, because phoning an ambulance quickly after recognising an overdose can save lives as well. So, in light of those things, that most likely somebody else is there when somebody overdoses, and opiates are one of the main substances involved in our overdose deaths, our national naloxone programme was launched, it was announced late 2010 and it was launched early 2011. This had been quite a long process, so a big change for us was back in 2005, where there was a change to the UK Medicines Act, which meant that anyone could administer naloxone to anyone for the purpose of saving a life. So that was a real big step that we were able to do that. And there were a couple of pilots that took place. So Glasgow and Lanarkshire did small-scale naloxone pilots, followed by Inverness, who did a small-scale pilot. And there were recommendations from the National Forum on Drug-Related Deaths, which is our main sort of advisory forum on reducing drug deaths in Scotland, that this should become more widely available, and the Scottish Government should look to support the implementation of a national programme and should fund it, which they did. So they fund the posts, and when I notice in the programme it says the SDF naloxone team, there's two of us, so it's the team that covers Scotland is myself and my colleague Jason, who leads on the peer education programme. So it's not a big organisation to deliver that programme, but there are other groups that lead the more strategic side. So we have a national naloxone advisory group, which has members from all different backgrounds, so prison representation, police representation, statisticians, information services division that collate all the statistics about it. So yeah, it was quite a long process, but finally announced. So the Scottish Government funds the posts, and they also fund the cost of the take-home naloxone kits, which at the moment we're standing at £18 and have now just been reduced to £15. So the way that it's supplied in Scotland is using what we call a patient group direction, which, if some of you haven't heard of that, it's essentially a written set of instructions that allows the supply or administration of prescription-only medicines without the need for the written prescription. So nurses and pharmacists are the main sources of supply across Scotland, mainly nurses working in community addiction teams, or harm reduction teams, although there's not so many harm reduction teams across Scotland, and nurses working in the Scottish Prison Service. Pharmacists working in needle and syringe programmes do it in some areas in Scotland, it's not all over Scotland, and some community pharmacists as well. So these are the main sources of supply. So generally how that would function is the nurses seeing people in CAT teams will have the discussion. They've hopefully already had the discussion with their clients about overdose prevention, and the addition of talking about naloxone should really just be a quick 5-minute intervention if that's all the person's got. We're not expecting people to have 2-hour training sessions with the whole resus mannequin effort, which was initially implemented at the start of the programme and quickly abandoned because we just weren't getting the numbers. We then had in place in 2011 the Lord Advocate Guidelines, which is the Chief Legal Officer in Scotland, allowed us to supply services who were going to be in contact with people who are potentially at risk of overdose. So we can supply services like hostels, homeless services, all sorts of services, and outreach workers so that they could use naloxone in an emergency. And a lot of the uses of naloxone have actually been from workers working in those situations. Fairly recent for us is new legislation that's come into force from the Medicines and Healthcare Regulatory Agency. There was a consultation went out to look at wider access to naloxone. So that was put in place on the 1st of October this year, which essentially means that naloxone will remain a prescription-only medicine, but that we won't need any prescriptions or prescription patient group directions to actually supply it. So for us in Scotland, it's helpful because it will mean that services like third sector agencies who don't have nurses or pharmacists attached to their service will be able to physically supply it. And certainly for us, the third sector have been the ones who've been most keen to drive the programme forward. So I would expect to see that when third sector agencies come on board with supplying it, that our numbers will greatly increase again. So that'll be interesting to see how that new legislation comes into practice.